great to have you back with us for Modern Aesthetics TV. We're at scale, and I'm really excited to have Dr. Vince Bertucci with us. Vince practices in Toronto. It's Stanley Cup time, so we're going to use a lot of Canadian terminology, like about. And specifically, you have covered a lot of injectable areas at this conference. The temple and the appropriate injection technique for the temple is one of them.
Yeah.
Walk us through.
Yeah, so sure. So first, I think if we back up a little bit, many patients don't come in asking about temple. And I think it's important to recognize that this area, the temple, both anterior on the non-hair-bearing part and posteriorly into the hairline, if there's a valley there and the rest of the face is full, it's kind of like an appearance that gives you an aged look. So I think looking at that and the proportions to the rest of the face is super critical. So what do we treat? And typically there's multiple different injection techniques. There's the interfacial, there's the subdermal, there's the one up, one over technique, and they all have their pros and cons. One of my favorite techniques is the subdermal technique. And so what I do is I enter here from just superior to the zygomatic arch, and I thread the product. For the anterior temple, a thinner product, because for subdermal, we don't want to make it show through and look lumpy bumpy. Posteriorly into the hairline, if it's recessed and it indents, then what I do is I use a slightly thicker product so that it's got a little bit more lift capacity and it can give you that volumizing that balances the face.
So more superficially with a cannula and deeper with a needle just to facilitate the planes?
So with what I just described, they're both cannula techniques. Both you can enter from the same location, and they're both subdermal, which I find is more efficient in terms of volume correction. So I feel like I can get a really good volume correction without, because when you go deeper, especially if you're doing the one up, one over, you're below the fascia, and if you've ever felt it on a cadaver, the fascia is super thick and dense, and you could literally pick up the head from the fascia, so it takes more product to lift up and out. With a subdermal, I find I can get more efficient correction.
And then just for our audience who are watching, one up, one over, we're talking about the orbital rim and going a centimeter up and then a centimeter over. So
lateral from the temporal suture line, exactly. So that's another technique which is really good for that transition as you move from the forehead to the temple, because oftentimes there's a drop off right there, and that's actually a really good thing. If you can blend it so that the cosmetic units blend one into the other, I think you get a really nice appearance. So it's an efficient way, but it doesn't treat like the lower areas, the posterior areas.
So let's move to neuromodulators.
Yeah.
I think we're excited about some of the new indications for things that we've been doing a long time. Platysma is certainly one of those.
Yeah, so Philip Levy from Switzerland first published the Nefertiti lift in about 2006, I think it was.
So it was Journal of Cosmetic and Laser Therapy, 2007.
2007. I was actually commenting yesterday that you are an encyclopedia when it comes to data publications. It's super impressive. Anyway, he published on it, which interestingly, the technique then was very similar to the approval that Allergan just received for their Onabot injections, with one injection row along the mandibular border or just below, and then into each platysmal band. The approved method is 5 injection points along the platysmal bands and 4 along or just below the mandibular border. So it's great, and I think the key thing is picking your patients well. So individuals that have jowls, that have what appears to be bands at rest but really is lax skin, they're not going to do as well. On the other hand, if you have individuals that are pretty tight at rest, but when you ask them to say E or show your bottom teeth and you see the bands, I have them, and they lose definition of the jawline, they do really, really, really well with that technique. And I think picking the patient's super important, and recognizing that you can give them the tight jawline, because almost no one comes in and says, hey, I want my platysmal band straight. No one says that. I don't find that. But when you explain to patients that you can actually define the jawline with neuromodulators, with botulinum toxins, it's a huge win for everyone.
So first, I think some patients come in and ask for a Nefertiti lift.
Yes.
So Queen Nefertiti, as we know, was the second most popular Egyptian queen. The first one was Cleopatra, who really made a name for chemical peels and having milk spoil. But Nefertiti was known for her beautiful jawline. And secondly, when it comes to that specific area, I think one of the potential pitfalls is somebody hitting the depressor anguli oris muscle or the depressor labii inferioris more medially. So I think conceptually we just need to focus on staying more lateral. And then the last thing is, who are the candidates? And you mentioned this a little bit. People don't necessarily come in asking for this. I find that there's 3 categories of candidates. One is people who've had a previous neck lift. Second is people who've had some submental procedure, whether it's submental liposuction or cryolipolysis type procedures, or even some of the deoxycholate phosphatidylcholine type procedures as well. And then there are patients who had normal age-related changes that just have prominence of the platysmal bands, but you're right. I think it's important that they don't have a lot of laxity, because really you can't see that.
Yeah, totally. And I think when you start to tell people about jawline definition, I think you're much more likely to resonate with the patients, because everyone wants a snatched jawline, so to speak. That's the terminology that my younger fellows tell me about and my younger patients tell me about. I think one comment, the DAO, I think it's actually okay to treat it, because if you are turning down the corners of the mouth, knocking it out a little bit would actually be good. I think, as you pointed out, the DLI you want to stay away from, because then when you smile, you won't be able to pull down on one side and you'll have asymmetry in the mouth. So that's just a little caution there, yes.
So my only point with that is the DAO and the DLI come together as a V, and that point of the V is on the jawline, and that's where you're injecting. So you just want to make sure that if you do hit the DAO, you're purely hitting DAO, and that you're not more medial where the DLI is, because that actually is a muscle that is named appropriately for what it does. It depresses the lip inferiorly.
Yeah, and I think another way is, apart from staying lateral, you can go just inferior to the mandibular border, where you're going to be less likely to hit the DLI in that particular location.
These are great tips, Vince. We appreciate you being with us for Modern Aesthetics TV, and we appreciate all of you joining us as well.
Thanks for having me.